Hello, this is Patrick Myers. I'm Associate Editor for CTSNet, and we're at the EACTS meeting in Lisbon. I'm here with three experts on managing the aortic valve in children, and so we'll be talking about that subject. So first off, we have David Kalfa from New York Presbyterian Columbia University, New York, Professor Rodolphe Mer from Linz, Austria, and Christian Brizard from Royal Children's Hospital in Melbourne.
Good afternoon.
So thank you for joining.
Absolutely, thank you.
So managing the aortic valve in children, we have different options, from repairing, which can be more or less complex, reconstructing with the Ozaki type of procedure, and replacing the valve, be it with an autograft or even mechanical valves. So we'll discuss these different options. Maybe we can start with you, David, with an option that's...
Can I interrupt you?
Of course.
So that includes the neonates, so critical aortic stenosis, neonatal management of the aortic valve.
I'm sorry, I didn't understand.
So the critical aortic stenosis and neonatal management of the aortic valve, that included in the topic there?
We can include that, absolutely.
Because it is, we feel very strongly that a patient should not have a balloon valvuloplasty, and we perform aortic valve repair or surgical valvotomy with some very precise management of the leaflet in neonates who need surgery, or he need an intervention. Very, very few of our patients have a balloon valvuloplasty, and we have papers to demonstrate that the surgical management is yield better outcome in terms of freedom from reoperation, freedom from recurrent stenosis or moderate regurgitation with the surgery. We feel that this is the best way to postpone the Ross procedure. And on the other hand, if balloon valvuloplasty fails, very often it leads to a semi-urgent or urgent Ross procedure in neonates. And we know that in neonates, the Ross procedure has a very poor long-term outcome in terms of survival of the autograft.
Yeah, actually, we strongly agree with this position about doing an surgical aortic valvotomy, compared to the balloon dilation, because basically surgically, you can control, what you are doing basically, compared to just a balloon dilation. There are some thickening, thinning of the valve that you can do, reductions of some nodules, and so on and so forth.
And it's true that you're not always looking for a perfect result at that first operation.
No, you don't.
Thinning.
You rarely have a perfect result, but you almost always have a competent valve and a gradient that is very manageable, and you can postpone surgery, further surgery, at least 6 months, often very long.
Yeah.
Well, I agree with you if these are ventricles which are really suitable for biventricular repair. But if there is any doubt about that, you have to unload the ventricle very radically. Any gradient should not be left.
Yeah,
and
absolutely.
The most radical unloading of the ventricle is the Ross-Conner procedure. You never can do a Ross or at least I can't do a Ross without a Conner procedure, without enlarging the left ventricular outflow tract to the appropriate diameter to put in the pulmonary valve. So this is, in all cases, is really gradient free, and the ventricle is totally unloaded. And for the ventricle, this is really a great advantage, especially in these borderline cases where the discussion is biventricular or univentricular. I mean, if the ventricle is big and definitely suitable for biventricular repair, if the subaortic area is fine, that's okay to repair it. But if there are any doubts about that, I would prefer the Ross-Conner procedure, because also the long-term procedure of the Ross-Conner of the autograft valve is, at least in our hands, it's not bad.
In neonates?
In neonates, yes.
And infants?
Yes. In neonates, when we do the autograft procedure in neonates, we did not have any reoperation up to a follow-up now of 17 years.
So we actually did very recently a meta-analysis of all the ROS procedures in neonates in the literature, and actually we present that on Saturday. And basically the results are that number one, there is a higher risk of mortality if you compare the neonatal ROS compared to a ROS, compared to later, basically. But long term, we were surprised to see that there was no increased risk of autograft dilation if you compare the neonates to the other patients. And finally, we also showed basically that in high volume centers, this difference in terms of mortality between the neonates and the other patient is much less compared to low volume centers. So, the neonatal ROS is definitely an option to consider, especially when you work like us, everybody here in large volume centers.
It's also so that there are special risk factors. Several risk factors were defined by my colleague. She has examined our ROS series, ROS Cono series very exactly, and there are actually 3 risk factors. That's the additional pathology of the aortic arch. If you have to do an aortic arch repair in a patient with a critical aortic stenosis, if you have to do it together, this is a risk factor. If there is an additional mitral valve pathology, which is quite frequently the case in many of these borderline cases, this is an additional risk factor. And if there is an EFE greater grade 2, then it's also a risk factor for a ROS Cono procedure. Otherwise, they do actually very well. If it's just a ROS Cono procedure with critical aortic stenosis, without one of these risk factors, the survival rate is quite high, at least in our hands.
Yeah, but we agree with that. But it's what we, at least when we based on the literature that is a bit more, not ancient, but a bit older, but 10 years ago, the literature from Philadelphia or the literature from Stanford or San Francisco, you had a rate of reoperation on the autograft that was quite high.
That's interesting because we don't have this
all that data.
experience. We didn't make this experience. We do it since 2000, and our incidence of reoperation is now in the neonatal ROS Cono is still 0, and we have 100% follow-up. So
having said that, we do occasionally do the neonatal ROS, and it's true that we have good outcome.
So
I think that the neonatal ROS is really an excellent option in patients basically who have a smallish left structure, right, where you want a perfect result, right, from a hemodynamic standpoint. But if you have 2 good ventricles, I think that I agree with you. The first step, commissurotomy is a very good option.
No, that's totally correct. I totally agree with you.
Yeah.
But we have this this fetal dilatation program, and with this fetal dilatation program, some cases of borderline ventriculitis, you get more cases of borderline ventriculitis than in other places.
Yeah.
And that's probably the reason why we have more of these borderline cases, and this is the reason why we are very keen to do these ROS Cono procedures, because they are very radically unloading these borderline ventricles, and we can make them biventricular. And they have actually almost, I think none of our patients has pulmonary hypertension in the long run, which is also a very important aspect.
No pulmonary hypertension.
No pulmonary hypertension, none of our patients. I think this is also a very important aspect of this group of patients.
So we've talked about critical aortic stenosis. Now if we get into bigger children, toddlerhood or even early teens, what are your preferred strategies, or how do you select your patients? So
I think that patient selection is extremely important. I think that there are basically different options, and they are not, competing options, but more complementary options. So you mentioned the aortic neocuspidization or Ozaki procedure. We mentioned the ROS and other options, and I think that there are good candidates for an Ozaki and there are good candidates for ROS. So our strategy at Columbia University is basically to still consider the ROS as a gold standard, right? Because we all know, the great advantages of the ROS, that's a living structure, that's autologous, that can grow, there is no anticoagulation, and most importantly, there is a great, follow-up, and we know, right, that the ROS is a great option long term. That being said, sometimes the ROS is not feasible, of course, when there is no pulmonary valve available for the truncus arteriosus patient, right? Or as an example. And also we know that there are some risk factors, right? To have non-optimal or less optimal outcomes for the ROS procedure, right? These patients who have a higher risk of autograft dilation, which includes patients who have preoperative aortic insufficiency, or patients who have also, of course, rheumatic disease or connective tissue disease, all of this. And then in this situation, I believe, and we believe at Columbia University, that the aortic valve neocuspidization is a very, very good option. So we are now offering these options. This option now we have median follow-up of about 3 years, median follow-up of 3 years. Around 15 patients have got an Ozaki procedure with interesting short-term results, but of course, so there are multiple potential advantages, right? We discussed about the fact that this can be done when the ROS cannot be done. Also in patients with some significant LV dysfunction, that's a surgery which is significantly shorter compared to a ROS, right? And of course, you do not, transform a one valve disease into a two valve disease. That being said, these neocusps are not living, right? They are made of material, right? Which can be autologous pericardium or any type of bovine pericardium. And all these biomaterials are not, perfect, as we all know. So at some point, they will fail, for sure. So the Ozaki is probably, just a first step.
Yeah, we don't use the Ozaki procedure. We believe that the best outcome in young population for the ROS is when you encase the autograft, and so that limits the range of size of patient whom you can do that. So we try to reach that size of patient with aortic valve repair as much as possible. When we have to do a ROS in a younger population, so from toddlers to teenagers, we would wrap the sinotubular junction with PDS band to prevent the initial dilation of the pulmonary autograft, and we have done that for the last almost 15 years with good preservation of the initial diameter. Initially we wrapped at the base as well. We've stopped doing that. It's only at the sinotubular junction. And we have had no complications, no reaction, no calcification of that. If you do reoperate on when there is a PDS band, it disappears completely and has it does not leave any scarring process.
So you put two bands, one at the level of the annulus?
Initially, we used to put two bands, one included into the suture line at the base and one around the sinotubular junction. Now we just put the one at the sinotubular junction. But that PDS band is going to disappear from the market, and it's very sad because it's extremely useful. We use it also for pulmonary artery banding in residual multiple VSD. Yes. So, and very often you can have a resolution of the VSDs within a few months and no need for reoperation.
Yeah.
It's a shame that won't be on the market shortly.
Well, we're putting pressure, and I'm doing that now. We're putting pressure on the company to try to carry on.
Absolutely. Okay. So how could we make the Ozaki procedure better in children? We
How do-
mentioned the issues of biomaterials.
Yes. So compared to what Ozaki described, what we do at Columbia University is to treat the because the autologous we prefer to use autologous pericardium when autologous pericardium is available, and then we treat it for a very, very short period of time, right, with glutaldehyde.
How short is short?
1 minute.
That's
Yes.
very short.
It's very short. 1 minute.
And you had no issues with breakdown of the pericardium during
No,
follow-up?
we didn't have, but that's a very good question. We had actually, so on the 15 patients, there was no reoperation and no more than a mild AI, right, at a mean follow-up of 3 years, unless one patient where there was no autologous pericardium available and we used a photofix and we had a mechanical failure of the patch of one of the cusps made of photofix, which didn't seem related to the reconstruction of the commissure because it was in the middle of the cusp, basically. So that was interesting, actually. We had a mechanical failure for a photofix patch and not an autologous pericardium patch.
You have no experience with the cardiocell?
In this, for the Ozaki, no. No.
Because Ozaki has worked with Admetus, and where there is an experimental work that
Yeah.
worked very well.
Okay. So that's another option, yeah. So that will be the first modification, for the pediatric Ozaki compared to the adult. And then the other modification is basically you do not have to respect exactly where the native commissures were, right? So for example, if it's a quadricuspid, bicuspid, or quadricuspid valve on a truncus arteriosus, you can, choose to put your commissure wherever you want. So that's actually another advantage, right, of this technique. It's a very versatile technique, right? You can, do whatever you want basically and size, where you want to size. So based on the commissures, right, and also on the coronary arteries, if you have any type of coronary arteries anomalies, right, in terms of origin or ostium, you can make sure that the ostium of the left coronary artery, is in the middle of one of the cusp, right, just to avoid any risk of compression or occlusion, right, and then based on that you can. I think that that would be the two main differences in terms of techniques. And then in terms of sizer, now we have the pediatric sizers, which appeared on the market something like, I would say, 1 to 2 years ago. So now we have the 13, 15, and 17 sizers, because before that, we were limited in terms of size. It was above 19.
So you use the Ozaki procedure in 13 millimeter aortic root.
Yes.
That's the sinotubular junction or the base?
The sinotubular junction, I would say. But actually there is no always, it can be, some discrepancy between the actual diameter of the root, right, and the sizer that you will use. Really? Because the sizers are sizers for each cusp. Yeah. And it doesn't correspond always to the diameter of the SCJ. So sometimes we can use 13 sizers in smaller roots, and sometimes we are not able to use 30 millimeter in larger roots. So there is not always. So
the Ozaki procedure usually produces a significant excess of coaptation, yes, and a very long free edge.
Yes.
You have never had any issue with coronary arteries occlusion?
Yes, personally I have not, right? But I know that in other centers, and so actually in Boston where the group has been very active in adopting this technique very early, I know that they had at least one case of coronary occlusion related to this very high height of coaptation, as you said, which is basically one of the concepts actually of the Ozaki, is to provide this very high increased height of coaptation.
And excessive coaptation.
Yes, yes.
And especially as you showed in your data with the asymmetric valves. That was before the Ozaki procedure, but in the cusp extensions.
In the cusp extension, we had some patients in where we experienced that, and the mechanism is always an excess of free edge. Length of free edge, not too much height, but length, and it's the infolding of the free edge that will eventually occlude the coronary artery.
Yeah.
Okay. Any other comments on these different techniques that we've been discussing?
The cusp extension, we continued using it in rheumatic patients because there is in Australia a large population of rheumatic patients. With it allows to go beyond the teenagers, and we have so far not had to reoperate on this patient. We use the cardiocell now that it is available to us. But the cusp extension that we were quite liberal with that technique early on in the 2000 and 2010. Now we're much more restricted in the congenital patients. In congenital patients, we do use the tracheospidization technique, but we limit the utilization of patches to the reconstruction of one commissure. So we just use two small triangles to suspend one commissure and try to minimize the amount of foreign material. On the other hand, when you have to when you resuspend a bicuspid valve in a large annulus with a very small resuspension of the commissure, we have very good long-term outcomes. It's very nice. But there are data from Germany that show that as well.
Absolutely. Thank you very much. I have one more option, which we're discussing, we're presenting on Saturday afternoon. You presented previously in completely different pathology, in TGA VSD pulmonary stenosis, where we'd normally do a Nikaido or a Rastelli type of procedure, or a Rev for the Parisians.
Or Dream.
For the French, sorry. You presented in following your papers, we started using a double root or double outflow tract rotation and recycling the valve, which was not adequate in the systemic position, putting it into the pulmonary position. And that made us think, well, the Ross procedure, people always complain about it because it's turning a one valve pathology into a two valve disease. Well, what if you could use that technique for congenital aortic stenosis or aortic valve disease? And so we just looked in a cadaveric model just to see if it was technically feasible to take the aortic and pulmonary roots en bloc. We did that in two cadaveric hearts, and it was feasible. We were able to reimplant it. Once we'd finished reimplanting it, we explanted and looked underneath the right non-commissure to see if there was any conduction tissue that would take in with the root, since the conduction would be not far, since we don't have the large VSD of PGA VSD. And in histology, we didn't have anything. So that's an idea. Now, a lot of surgeons don't do a Ross procedure because it's too complex, and here we're looking at something that's even more complex, and with no idea what that will give later on down the road with pulmonary valve that is,
I think it
neopulmonary valve that's
it might be a good idea, yes. I think it might be a good idea.
We do the double root replacement now almost every time we have to do a Nikaido, or Beck's Nikaido, being French. Technically it's not very demanding. The harvesting of the pulmonary autograft is not very demanding, but it has to be considered. The result of the pulmonary valve repair in tetralogy of Fallot is not outstanding.
Yes.
So you may have great disappointment despite a lot of effort.
Absolutely, and we're still lacking long-term. I think you probably have the longest experience of that procedure in transposition. We've just started, and got to give credit to my associate in Geneva who did these procedures, and we did these models together.
Well, concerning the pulmonary valve, sometimes you have to use a transannular patch. This is about in about 1/3 of the patients. But yes, 1/3 of the patients is about. The rest of the patients, there's 66%, about 2/3. The pulmonary valve is fine. There may be a sort of a gradient there, but it's more like in transposition. The stenosis appears at the distal anastomosis of the pulmonary artery and the pulmonary root. It's not the neo, it's the real pulmonary root then. But there we had two stenosis which could be dilated. So we didn't have any reoperation. We had some dilatations, redilatations, reinterventions on the pulmonary route, but not no reoperations up to now. It's
What's your median follow-up?
pardon?
What's your follow-up, the median follow-up?
I don't know the median follow-up. The maximum follow-up is now 16 years.
16 years.
Yes.
So essentially, it sounds like
Yeah.
with tetralogy, as you were saying, that this valve is not perfect.
It's
We
not
can
perfect.
get by. There are reinterventions, maybe reoperations down the road, but time will tell.
Yeah, but for a pulmonary valve, it's sometimes better than a homograft.
Okay. Well, thank you very much for this very nice discussion,
Thank you.
Thank you.
and have a great meeting.
Thank you.